Welcome. Hope you guys had a great New Year's Eve. Looking forward to another year of IG Lives every Monday night with you guys, 6 p.m. As always, you always submit some great questions ahead of time. I try to answer as many as I can in the first half hour. If you're interested in working with me potentially, I still do have some slots open. Looks like I'm booking out, at least 2 months in the future at this point. But if you want a real deep dive into what's driving some of your cardiovascular concerns, then just check out my website, drtwyman.com, and apply there, and somebody from my team will set up a meeting with you. So let's just jump right in. First question of the night. What do I tell people that are on certain medications that are told to stay out of the sun? Well, it's going to depend on what medication, but there are certain antibiotics and anti-seizure medicines that have an effect that make you photosensitive. Some of them can cause a rash, some of them cause some major, allergic issues if you go in the sun with these medicines on board. So I would ask the person who's prescribing the drug if there's any other options other than what they're prescribing you. If it is something, what is the shortest duration you can get away with using it? You just want to avoid being on any type of lifetime medications that make you photosensitive. All right. Somebody's asking, could I explain the vortex function of the heart? So this must be somebody who's very into quantum biology. There's a book, The Human Heart, by, I believe, Cowan. That's an interesting book. I think that's where I first learned about the idea of something called a chestahedron, a seven-sided polygon structure that could simulate what the left ventricle would do. So it's estimated that you have nearly 60,000 miles of blood vessels, and it would not be very likely if you just had a pump that would be able to send the blood through those 60,000 miles of blood vessels. So the thought is that your arteries are lined with a coating called the glycocalyx. If that coating's healthy, then what's above it basically slides on by. So the heart will essentially vortex the blood out of the left ventricle into the aorta, and then kind of like a wet willy or a slippery slide, then the blood just slides through the system. And the glycocalyx is heavily sulfated with structured water, and it's going to allow that flow to continue. So the vortex portion of the heart is useful to keeping the blood flowing well. Question about red light therapy. Does it benefit the heart? It does. Generally, it's indirect. Most of the wavelengths of light are not going to penetrate all the way into the myocardium, but you can get peripheral benefits. You can activate stem cells. There was a study done in Israel, patients who had a myocardial infarction, so they're having a heart attack. They were taken straight to the cath lab. Half the group got treated with standard of care, where they got a stent and regular treatments. Half the group got the same, but they also got a red light therapy at the time of the cath. It was administered to their shins for 3 minutes. There's, I believe, post-op day 1 and post-op day 3, if I remember right. But those individuals that got treated with red light therapy had decreased elevations of their cardiac enzymes, which indicates they had smaller heart attacks. The thought would be that it stimulates the stem cells and it goes to the ischemic myocardium and helps stabilize the heart while they're waiting for the coronary reintervention. So that's how directly it would benefit the heart, but it may help with lowering blood pressure as well. When red light therapy interacts with the mitochondria, nitric oxide is kicked out of the fourth cytochrome and diffused peripherally, and it can help vasodilate arteries. There's a question about looks like 36-year-old resting, nighttime heart rate in the 70s. What's the best way to lower it? Add regular cardio. First got to rule out if there's any metabolic reasons why the heart rate is elevated. 70 is not that high, but if you're hyperthyroid, if you're anemic, those can be some things that will drive it up. Caffeine in some individuals, if they're slower metabolizers, affects their resting heart rate. So exercise is one of the best drugs to stabilize the vagal tone. So yeah, adding some zone 2 cardio in. So 80% of your exercise in the cardio zone should be zone 2, and then depending on your fitness level, then maybe you're doing one zone 5 kind of VO2 max type of sprint hit training a week, and that should over time lower the resting heart rate. Normal heart rate's between 60 and 100, but the more cardiovascular conditioned you are, generally the resting heart rates will be in the 50s and 60s. All right, how long does it take to reduce soft plaque in the heart after implementing my strategies? Great question. It really depends on what is your comfort level on waiting to repeat imaging. There are studies that can show that soft plaque in the carotid arteries can shrink within 4 months of optimal therapy, but there are cost concerns depending on what imaging you're using. There's a CT coronary angiogram that is called the Cleerly scan. The out-of-pocket cost to a patient could be nearly $2,000. I've had the scan previously, and when I repeated my test 2.5 years later, the soft plaque had shrunk approximately 6% in that time frame. So unknown did it change in the first 6 months or 1 year, but within 2 years, the plaque was significantly regressing in the right direction. Can you reduce hard plaque in your heart using enzyme therapy? I would say unknown, and I don't know if that would necessarily be the goal. Once the plaque is hardened and calcified, think of it as a scar. Do you really want to remove a scar if there's more unstable plaque below the scar? Have I seen calcium scores improve going down? Yes, but typically only when the calcium score is less than 100 have I seen them reduce significantly. If your calcium score is 1,000, that's very high risk. If you repeat the test, often you're going to see the calcium score test going up because you're adding a lot of therapies that are starting to stabilize the soft plaque and turn it into more hard plaque. As for enzyme therapy, it really depends on what you're asking. If you're talking about nattokinase, I had that question pop up 2 or 3 times a day during some telemedicine calls. You really need to use high doses of nattokinase. In that case, there's only one study that's ever been done, so I'd like to see a repeated study before routinely recommending that for people. And I looked at the cost if you're really going to do that. 10,000 forming units of nattokinase is going to run you about $100 US a month. How unusual is it for a female who's 43 to have heart disease? Her doctor made it seem like it was very unusual. So I would have to assume that when you mean by heart disease, that you have known plaque in your coronary arteries, either through a elevated CT coronary calcium score, you've had a CT angiogram that assessed that you have soft or hard plaque in the arteries and some stenosis, or you've had a coronary angiogram and they've visualized plaque in your arteries. 43 would be early atherosclerosis. Is it unusual? I would not say as much as it was in the past. I've unfortunately started seeing people in their mid-30s with plaque. It tends to be more men than women. So my concern would be for somebody who has plaque less than 50 years old, that they have lipoprotein a until proven otherwise. They may have 9p21, the heart attack gene. So you have to figure out what's causing this heart disease at such an early age. It's complex, but I usually break it down to 3 buckets. Is there something that's affecting the nitric oxide pathways in the glycocalyx? Is there something that's causing oxidative stress and inflammation? And thirdly, is there a lipoprotein abnormality, including elevated lipoprotein A? And if you have access to a calcium score report in labs, there's a calculator called the AstroCharm calculator. So created by NASA, I believe, or at least was studied on astronauts. If you plug your data into the AstroCharm calculator, it'll give you an estimated 10-year risk of having a heart attack based off your current results. And that's what you care about. Plaque is common. If you live long enough, you develop plaque in arteries, but 40 is relatively early. What you really care about is that plaque stable. Are you going to be able to live your life doing what you want to do, or are you going to be having cardiovascular events? Okay. Do I have any general thoughts on Adderall usage for those post-heart attack? I would just want to make sure that you have a normal baseline EKG and normal blood pressure on the medication. If that's true, good to go for the most part. But if it's affecting your blood pressure, you got to use something. If your lifestyle alone won't get your blood pressure back down, to get the blood pressure ideally back down to less than 120/80. Somebody's asking about how should you best use the EMR Tech FireWave at home. So EMR Tech is a company that I have multiple other devices of at my office at Apollo Cardiology. I have their 8-foot tall FireHawk. That's the full body panel. I do have the FireWave in the office, and that's the one I use to demo PBM therapies to patients. Best use it? It really depends one-on-one with talking to somebody who is aware of its best use cases and what other things is going on with the patient. So I can't give any general recommendations on how to use the device. I'd have to know what the person's context is and what they're trying to treat. Can lots of plaque buildup lead to excessive fatigue? Yes, it is possible. Not everybody has the classic elephant on their chest or significant shortness of breath. It's usually brought on by exertion, but particularly in women, sometimes their symptoms are more vague. They may just have nausea, or they may have just general fatigue. So if they've done workups and it's not your thyroid, you're not anemic, you don't have sleep apnea, then it may be worthwhile to do a ischemic workup. They could consider doing a exercise stress test, plus all the other testing I usually talk about. Things that look at endothelial function, looking for soft plaque in the carotid arteries, looking for hard plaque in the coronary arteries. It just really depends on what other risk factors go on. But yeah, definitely if you have excessive fatigue and it's not a hormonal issue, you want to talk to your doctors to rule out a cardiovascular cause. Looks like we have about 3 more questions pre-submitted. So, which vitamins and minerals are beneficial for good functioning of the heart? Sunlight. That's really the thing that the body needs. You need your light environments right first. Before we start talking about vitamins and minerals, you want to make sure that the person's circadian rhythms are in check. The name of the game is collecting electrons. So getting electrons by grounding, getting electrons from the light from the sun striking your surfaces and charge separating the water in your cells. That's how your body runs. The energy cycles is with the electrons from those processes. The DHA from seafood is critically important. I really want people to get it from their diet. Will I supplement on occasion, but it's always inferior to getting it from diet. And then minerals, magnesium's, a lot of people are deficient in it, but I can't make general recommendations on what people should take. I would need to know their context and ideally look at a set of labs to make sure they have normal kidney function, and I can really kind of fine tune what you're deficient in. What supplements did I take to lower the plaque in my arteries? I took a nitric oxide promoter, I took a glycocalyx promoter, and I took Kyloic aged garlic. Is the iHeart pulse wave velocity device a good choice? Is there a better option? No, I think it's a good choice. I was recently at the American Academy of Anti-Aging Medicine, A4M, their event in Las Vegas. It's the Longevity Fest that they have every December. They have an enormous expo hall with thousands of vendors. I was actually a guest presenter at the Cowboy booth, where I brought a lot of my I call vascular health toys to their booth, and spent I think I was there for an hour and a half doing demos of the different devices. And I did bring my iHeart. I do think it's probably one of the better pulse wave velocity tests that the average person has access to. You can get them on Amazon. I believe they're about $100. Like anything, rarely is one device going to be the be-all, end-all. I always say that you got to have the devices kind of rhyme, because sometimes the device, will be variable day to day. So I wouldn't freak out too much if your results are not good on one day. It's really what is the trend on those type of devices. All right. Excellent questions tonight. Excellent way to start the year. All right, I got a question in the comments. So it looks like a relatively young person, 37-year-old, high total cholesterol in the 270s, HDL. Looks like it's, holy cow, is that really 165? No, LDL 165. HDL in the 70s, trigs in the 70s. Very fit, no other comorbidities. So, it's elevated, but it's not classic familial hyperlipidemia, so not likely genetic, where you have a monogenic gene or one gene gives you, quote, high cholesterol. But the traditional sterile panel is not super useful at predicting risk. You really do need to look at the lipoproteins that transport those cholesterols through the blood. Cholesterol is a waxy fatty compound. It's not going to float in your liquid blood. So you need to measure the lipoproteins, the lipid protein carriers, particularly the LDL particles. You can also look at apolipoprotein B. So in my office, I often use an example of a tennis ball. The lipoproteins are the tennis ball. They're full of the cholesterol. They're full of fats. They're full of fat-soluble vitamins, and it's full of something called phospholipids, which are building blocks for the cell. And on the outside of that tennis ball is a white stripe. That white stripe is a structural protein analogous to ApoB. It also acts like a key to bind to different receptors. So get a traditional lipid panel. It's a good starting point, but if you want to know more, you really need to look at the particles. And then particles are just one part of the equation I talked about earlier. You need to know what's going on with your nitric oxide and your glycocalyx. You need to know how much oxidative stress and inflammation you have, because those are the starting points to have issues with the arteries. Cholesterol is just somewhat the innocent bystander to begin with. So potentially also look at testing that looks at endothelial function. Look, do you have an abnormal carotid intimal medial thickness scan, which is an ultrasound of the carotid artery, looking for inflammation in the artery, looking for soft plaque in the artery, or consider looking at a CT coronary calcium scan depending on your age. If you're over 35, a calcium score test might be useful. All right. Someone's asking, can CoQ10 and Vasconox be taken at the same time in the morning? Likely, there's not a supplement interaction with those, and definitely want to take Vasconox in the morning. It has a very long half-life, and if you take it in the evening time, might cause you to be a little bit more alert when you don't want to be. So he says, give me some thanks. You're very, very welcome. I always enjoy answering your guys' questions. I don't have a perfect New Year's resolution, but less but better is kind of the motto that's coming to head right now. Is that I know I won't be able to see every single person who wants to be one-on-one with me at Apollo Cardiology. My practice is not full at this time, but it's very likely to fill up this year. And to be honest, I don't suspect I'm going to expand. I just really like taking care of the patients to take care of. I don't want to be a quarterback to a whole host of other doctors or nurse practitioners or PAs. I want to be able to be the one helping the patient directly. So if you're working with me right now, great. I'm gonna continue to see whoever's already in the door. Essentially, I will be having a kind of a new program for people who want to work with us. We've classically been doing something known as a 2-part deep dive. So the first visit is always in our office in St. Louis. A couple reasons. One, it's always better to meet people face to face. Technology is amazing, but it's better to sample people's biophotons in person. You can also then obviously do a physical exam, so you can listen for carotid bruits, you can listen for heart murmurs, you can check for abnormal blood pressures. Is your right arm higher than your left arm? And then we have the whole host of vascular testing equipment in our office. So, we have tests that can look at the health of your arteries and your carotid. We have device that can look at how well your arteries release nitric oxide. We have a test called the MaxPulse, which looks at pulse wave velocity. So that's the clinical grade version of an iHeart monitor. We have a device that looks at, do you have an aneurysm in your abdominal aorta? We have a device that looks at the blood pressures in your arms versus the blood pressure in your legs. So that's an ABI, an ankle brachial index. We have nitric oxide testing strips, and then we have access to all the fanciest advanced cardiovascular labs that we can draw in our office and ship them all out at the same time. So it is really a one-stop shop. The only thing we don't do in the office is we don't do the CT scan. We just refer you out to that if you need one of those. And then the follow-up visit usually is 2 to 3 weeks later. Today I spent some time talking to some of my telemedicine patients remotely via Zoom. Spent an hour with them going through the results of any of the imaging tests we did with them, and then any of the biomarkers. And then we come up with a good lifestyle plan. So we talk about their light environment. We talk about their sleep, their stress, their nutrition, their exercise. If they're on supplements, I'll talk about which ones seem reasonable and which ones are superfluous and they don't need. And then we talk about pharmaceuticals. We use them for people who are higher risk, but usually have some genetic markers that kind of tell us who's more likely to tolerate certain medicines than others, and then send them out with that plan. So after the 2-part deep dive is complete, the patient's free to take that information, that wellness plan, and work with their local doctors, or if they have another cardiologist somewhere, they can work with them. If they're wanting myself and my team to continue to manage them, usually we see them about every 4 months after that point. And that can be remotely for at least the first year, but usually every 12 to 18 months, we have a live visit to kind of catch up on some of that testing. So that will continue to go on this year. We did, let's just say a lot of people last year after some of my podcasts with Drew Purohit and Dave Asprey dropped. Going to likely be on some bigger podcasts again this year. Some of the dates are still pending. I'll let you know when I'm actually booked for some of them. But at some point, we will have kind of more of a maintenance program. We do have kind of a limited membership program right now. Those people are going to be grandfathered into that program for as long as they want to be members. But we'll have kind of a new membership rolling out to people who are new to our practice. And just think of it like a 12-month kind of maintenance program to make sure your vascular health is optimal. So be looking forward to releasing some more of those details going forward. I know I've been very lax on sending out newsletters in the past year. That's just on me. I'd have to make time for that. Like I said, I can't take care of everybody one-on-one anymore, so I'm going to start trying to do more one-to-manys via these kind of platforms. So I will start sending out at least one newsletter a month. Maybe I can get back to once a week, but at least once a month. I will put some of the content together that has data about what I'm currently reading, what podcasts I find interesting. If I've been on a podcast or interesting YouTube episodes, I'll post some links in there. And then I always get a lot of questions about the gear that I use. If you're interested, I'll start putting more links in the newsletter for that as well. So, all right, I think there was another question popping up, and then I'll wrap it up for you guys tonight. All right. So, does using red light therapy at, I can't see this too well, 5 a.m. long before winter sunrise disrupt your circadian rhythm? Not really, but the best time really is to use it, from sun up to sundown. I basically violate this rule. I use most of my red light therapy early in the morning. I'm up by 5 a.m. every single day, and the sun isn't rising until about 7:15 right now. If you saw my story today, that was live. I was outside. It was wind chill of 2. Went out for a 50-minute zone 2 type of hike. Was bundled appropriately, but I'm pretty good with my cold thermogenesis exposure, so it really wasn't that cold. But you just want to be careful on the timing of the red light therapy in the evening time, because it may affect people's sleep because of the intensity of light. So if you're using it in the morning, you probably should not have an issue with it. All right. Somebody's asking, did I happen to read the book Good Energy? No, I have not. I don't have any particular thoughts on it. I mean, I know it's in part about mitochondrial function, and it's written by the lady who runs Levels. So continuous glucose monitors. I think it's, from what I've heard, kind of more of a food centric type of book. Okay, interesting. I'm much more interested in the light, how it actually affects metabolism. All right. But I don't see any other questions coming in at the moment. As always, I appreciate your guys' time and attention. I'll be back here for you guys next Monday, 6 p.m. Central Time. And if anything pops up in the interim, just reach out to me in my DMs here. Or if you're actually interested in working with me one-on-one at Apollo Cardiology, go to my website, drtwyman.com, and apply there. So hope you guys have a great week.